Our first speaker today is Farah. She got her MD degree at George Washington University Medical Center, and she came here and did a residency, and then she was in the Office of Cancer Complementary and Alternative Medicine, where she was a director of case review. And now she's in CCR, seeing patients. She's a staff clinician. Her title, Breast Cancer Overview, Prevention, Diagnosis, and Treatment. Farah.
Thank you. Okay, so my talk today is it's going to be a general overview, and as Terry said, I'm going to talk about prevention, diagnosis, and treatment. In the end, I'm going to talk a little bit about the trials in our group and also a little bit about how the genomics era has changed the strategies for treatment in breast cancer. All right, so let's start with some statistics from the American Cancer Society. So we know that about 1 in 8 US women will develop invasive breast cancer over the course of her lifetime, and that translates to a 12.4% lifetime risk. And about 1 in 1,000 men will develop invasive breast cancer over their lifetime, and that translates to a 0.1% lifetime risk. The prediction from the American Cancer Society for 2018 is that there are going to be 266,120 new cases of invasive breast cancer in the women, and 63,960 new cases of non-invasive, or what we call in situ breast cancer. For the men, the prediction is 2,550 new cases of invasive breast cancer. This graph depicts incidence, mortality, and 5-year survival. This is from the NCI's SEER program. As you can see, starting from about 1979, there was a steady increased incidence of breast cancer. And I think this was likely due probably to the push in screening efforts and the diagnosis of localized cancers that we saw. Then around the year 2000 or so, we saw a slight downtrend in the incidence. And that's about the time that the Women's Health Initiative study was reported that had linked hormone replacement therapy to breast cancer. So that is a possibility in the slight downward trend. The mortality rate in the US has been declining steadily since 1989, when it peaked at a rate of 33 deaths for every 100,000 women. And the survival rate has been steadily increasing. And you can see that these changes are actually more prominent for women who are less than 50 in age. And it's due mostly to treatment advances, early detection, and increased awareness. This is also SEER data from the National Cancer Institute. It's showing incidence and mortality by race. The blue line in the graph represents African American females. The red line represents white females. And for African American women, you can see that the incidence rose sharply from about 1975 to 1990. Then it finally reached a plateau. For the white females, the incidence has always been higher than African American females. It rose sharply between 1980 to 1985. And again, that may be in part due to this increased screening efforts and detection of localized cancers. But then more recently, the incidence has declined and reached a plateau. But mortality has been slowly declining for both the African American population and the white females. But it has always remained higher for the African Americans. So the bottom line is, overall, African American women are more likely to die of the disease. Just briefly, this is the structure of the breast. The breast is composed mainly of fatty tissue. It also contains a network of lobes that are also broken down into lobules that contain the milk glands and tiny ducts that interconnect everything. And there's also blood and lymph vessels that run throughout the breast. About 90% of the cancers start in either the ducts or the lobes, and the lobes are the actual glands where the milk is produced. So what are the risk factors for breast cancer? So precisely, we don't know why a specific woman develops breast cancer. We know that it is a combination of genetic factors, environmental factors, and lifestyle. Hormones have an important role. Research has shown a link between estrogen levels and the risk of developing hormone receptor positive breast cancers. Other known risk factors, we know that age is a risk factor. The majority of breast cancers occur after menopause. Also, if a patient has had a prior breast cancer, they're at a higher risk of getting a new breast cancer. If a patient has a history of hyperplasia, which is too many cells, or carcinoma in situ, which is atypical cells within the duct itself, that is actually a risk factor as well. Again, like I said, exposure to excess endogenous or exogenous hormones through either early menarche, late menopause, the use of hormone replacement therapy in the past, which we don't do anymore, or if a woman has not had any pregnancies until the age of 35, that's also gives her more exposure to hormones. Also, if a patient has a history of breast biopsies, it's not the biopsy itself that increases your chance of cancer. It's the fact that the patient has some sort of atypia or something that's noted on a mammogram, which eventually will come out as a cancer. Also, if the patient has had radiation before the age of 40, for example, if they've had young women who've had Hodgkin's lymphoma, there have been cases of breast cancer following radiation in that area. Or if a patient has dense breast tissue on mammogram, and dense breast tissue just means more of the glandular tissue where cancers can form, and less of the fatty tissue. Also, lifestyle factors such as if you drink alcohol, you don't exercise, you're fat, produce more estrogen in the body. So we know that family history is definitely an important risk factor. If your mother, sister, or daughter has developed breast cancer before menopause, you are 3 times more likely to develop the disease. If 2 or more close relatives, such as cousin, aunts, or grandmothers, have had breast cancer, you are also at an increased risk. All right, so as I said, family history and genetics is an important risk factor. Cancers occur when there's a buildup of mutations in critical genes, and that results in the cell growing and dividing uncontrollably. In the majority of cases of breast cancer, these genetic changes are acquired over a lifetime, and they're present only in cells of the breast, and these changes are called somatic mutations. And these changes or these mutations are not inherited. However, less commonly, germline mutations, which present in all cells of the body, are inherited from a parent. In many families, we also don't really know what the genetic changes are that are associated with hereditary breast cancer. So there's a lot of research that still needs to be done. So some of these genes listed here are important in breast cancer risk. Of course, you know BRCA1 and BRCA2. They are involved with familial breast and ovarian cancer. BRCA2 is associated as well with male breast cancer. Both of these genes have a high penetrance, which means that if you do have a mutation in either of these 2 genes, you have a high likelihood of developing cancer. The protein from both of these genes is involved in homologous repair. P53 is also prevalently found in breast cancer. It's a tumor suppressor gene, as you all know. It is also of high penetrance, and if you have a mutation in P53, that puts you at a high risk of developing breast cancer. A mutation, obviously, you know, causes unchecked cell growth if you have a P53 mutation. RB1 is also a tumor suppressor. Same thing, it causes a mutation will result in unchecked cell growth. It's an important part of the checkpoint pathway. P10 is also a tumor suppressor. It's also a high penetrance mutation. Then there's also HER2, also known as ERB2. It's an oncogene. It's amplified in 20 to 30% of breast cancers. It encodes a tyrosine kinase growth factor receptor, as you know. c-MYC is an oncogene. It's amplified in 15 to 25% of breast cancer. And it encodes a nuclear phosphoprotein. So if you have a germline mutation, it does not mean that you are definitely going to get breast cancer. It really is a combination of the germline mutation plus other mutations we may not know that result from environmental factors, lifestyle, and that's what results in either you developing cancer or not having a cancer. If a patient has a mutated BRCA1, their lifetime risk of breast cancer by age of 50 is actually 49 to 73%. And by the age of 70, that risk rises to 71 to 87%. But if you have both a BRCA1 and a P53 mutation, your lifetime risk of developing breast cancer is about 85%. All right, so this is Breast Cancer Awareness Month. So I always seem to do my lectures in October, so I always like to talk a little bit about early detection. I think that's very important. So mammograms, as you know, can be used as a screening tool to detect early breast cancer in women experiencing no symptoms whatsoever. You can also diagnose if you have a symptom such as a lump, pain, or a nipple discharge. It does reduce mortality by 26% in the aged 50 to 74 group and 17% in the younger 40 to 49 group. And I don't know that difference in number. You would think it would be the other way around, but I think it's because the younger age group actually usually has more aggressive cancers. You see more triple negative cancers in the younger age group, which are more pathologically aggressive. So let's look at American Cancer Society guidelines for the early detection of breast cancer. So for women who are at average risk, so those who are between age 40 to 44, these women have the choice to begin annual mammograms. If you are between 45 to 54, they do recommend you have an annual mammogram. And 55 and older, you have the option of switching to every 2-year mammograms, or you could continue annual based on risk and benefits. So a woman's screening should continue as long as a woman is in good health and life expectancy is at least 10 years. For patients who are a high risk, so these are patients who have a lifetime risk of breast cancer of greater than or equal to 20 to 25%, using some sort of a assessment tool based on family history. A lot of times if people have a strong family history, they do see genetic counselors and have specific, and they're aware of what their risk is based on specific criteria. So if a patient has a known BRCA1 or BRCA2 gene mutation as well, they are at high risk, or they have a relative with these mutations but have not been checked themselves, or if they've had radiation due to other things such as lymphoma. And for these patients, they also recommend an annual MRI along with a mammogram. So as far as the use of MRI, just to say a little bit about that. So while MRI is more sensitive than mammogram, it also has a higher false positive rate. And so this may lead to unnecessary biopsies and other procedures. So it's not something that everybody should do, but it should only be done in certain situations. The American Cancer Society recommends against the use of MRI for women whose lifetime risk is less than 15% for that very reason. You don't want to subject yourselves to unnecessary biopsies, stress, all those things. For women who have a moderately increased lifetime risk of breast cancer, there is not enough evidence to make a recommendation either way. So in some instances, a radiologist may recommend it depending on what is seen on the mammogram. If MRI is used, it should be in addition to and not in place of a screening mammogram. So what does the American Cancer Society guidelines say for the clinical breast exam and the self breast exam? So there is no solid clinical evidence that a physical breast exam done by either a healthcare professional or by the women themselves actually has any clear benefit. So they're just saying that there's no clinical trial evidence. There's no trial that's been run to show that. So due to this lack of evidence, the ACS does not include it in its guidelines, but that does not mean that it actually does not help each individual woman. I think there's definitely benefit for an individual woman simply because there's not been a clinical trial that proves it one way or the other. It does not mean that women should not be aware of their own. I think women are the best detectors of changes in their own body. So I think all oncologists, all physicians do recommend that women be familiar with their own breasts and to do the self-breast exam. It's just not part of the ACS guidelines. So since this is Breast Cancer Awareness Month, and I always do this in October, I just like to throw this up here and just show you how a self-breast exam is done. I think it's important for all women to be aware. So first, it's just about looking. So you stand straight, look in the mirror, shoulders straight and your arms on the hips, and you're just looking for any changes that you see. Changes in size, shape, color, dimpling, puckering, retraction, thickening, inverted nipple, nipple distra, anything different. And you do the same with your arms above the head. Then the second part is about feeling. And so first you do it lying down and then you do it standing up. And you basically just have to use a firm, smooth touch. And whatever pattern you use, you just have to follow a specific pattern and just cover the entire breast. So the diagnosis of breast cancer is definitely a journey, a difficult journey. A woman first detects an abnormality, maybe on a self-breast exam, or a doctor will find something on their annual visit, or you find something on a mammogram. So the difficult journey starts there, and that is just the beginning. Then from that point, the patient will have a surgical consultation. The surgeon will probably, if they can feel the lump, they'll just go ahead and do a fine needle aspiration in the office. If the lump cannot be felt, then a core biopsy will have to be done under ultrasound guidance. And that tissue is then sent for a pathological diagnosis. And then if it turns out to be cancer, then the surgeon has to consider what kind of surgery needs to be done. Should it be a lumpectomy, just taking out the lump from the breast using a wide local excision, or does the patient need a mastectomy? And then, of course, there's different kinds of lymph node operations. You can have a sentinel node or axillary nodes, and I'll talk about that. And during the surgery, after the surgeon takes out the area, they'll send it for a frozen section to make sure that all of the cancer has been taken out. And also, they'll take a look at the lymph nodes for cancer. Here you see the diagram of the lymph nodes that are important in breast cancer. It's basically the axillary chain and the supraclavicular and subclavicular nodes, as well as all of the mediastinal nodes. And these are the nodes that mainly drain breast tumors. So we know that, unfortunately, cancer cells, once they become invasive, they do escape into the lymphatics, and that is the way they travel to other distant organs and cause metastatic disease. Once they break through the wall of the duct, they are now called invasive, and they're able to travel. So the different kinds of lymph node sampling during surgery, the surgeon can do an axillary lymph node dissection, and that's the traditional procedure that has been used for the longest time. It involves removing 10 to 30 of the lymph nodes in the armpit, the axillary chain that's closest to the tumor. The benefits are that all of the lymph nodes can be examined for cancer, and it's reliable. But the drawback is that there are complications. Patients can have the swelling, the lymphedema, they can have nerve damage, they can have infection. So at least over the past 15 years, people have been moving towards sentinel lymph node biopsies. It's a less invasive method to determine if the axillary nodes contain cancer. It has fewer complications. It is the current recommendation for patients with early stage breast cancer who are clinically node negative. That means that when the physician is palpating the axillary area, the physician is not able to feel any nodes. So that would be the biopsy of choice. So during surgery, the surgeon will inject isosulfan blue or technetium-99 near the tumor or under the nipple, and the tracer in the dye is mixed with the fluids and travel to the lymph nodes. And the sentinel node is the first node that receives the drainage. The surgeon will then remove either that one node or the cluster of nodes that gets the dye. So the surgeon then will send the final, after the surgery, they send the final tissue pathology report. And we always look at other markers with the pathology that include ER/PR, HER2, and then the surgeon will refer to a medical oncologist, and also radiation oncology will, it's a multimodality approach. Everybody comes up with a plan on how to treat the patient. So the patient has to be staged. Staging is definitely an important tool to determine the prognosis and treatment strategy. The main things that we look at in staging are the size of the tumor, the nodal status, whether nodes are positive, how many nodes are positive, if there's metastatic disease. A tumor is stage 0 when it's only within either the duct or the lobule. At that time, it's known as carcinoma in situ, but once it goes outside of the duct or lobule, it's an invasive cancer, and the staging proceeds accordingly to the size and the number of nodes and whatnot. And I'm not going to go through the different sizes. You can look at it. It's in the handout. So inflammatory breast cancer, I just wanted to mention, is a specific, it's a rare form of breast cancer. Well, here you see malignant cells that are infiltrating and clog the lymphatic vessels under the skin of the breast, and that's the dermal lymphatics. The blockage in the lymphatic vessels causes red, swollen, and dimpled skin, the classic sign of inflammatory breast cancer, and I'll show you some pictures in a minute. So the guidelines for diagnosis, you need a minimum criteria for a diagnosis of inflammatory breast cancer that would include a biopsy from that breast showing invasive carcinoma, and also a history that shows rapid onset of erythema, edema, and a peau d'orange appearance, which is like the appearance of an orange peel. And you'll have abnormal breast warmth. You don't have to feel a lump. This is the difficult part of diagnosing this disease, is you don't actually feel a lump. And the symptoms for most women, it should be less than 6 months. And erythema usually covers at least a third of the breast. This is a picture of inflammatory breast cancer. You can see the peau d'orange appearance to the breast. Since the skin is darker, you cannot necessarily appreciate the erythema in this patient, but that's what makes it a very hard diagnosis. It often looks like infection, and I have seen many patients, unfortunately, that go to their primary care physician, who is the first person that patients will see usually, and something like this can go undiagnosed for sometimes 6 months, unfortunately, and enough time for things to really get out of hand. These are actually pictures from some of my patients. how different and varied it can look. This is all inflammatory breast cancer, but clearly some of these you would think it could be an infection, and can go misdiagnosed for quite some time. So what are some of the prognostic and predictive factors influencing treatment decisions? So we know, as far as treatment, breast cancer is treated with a multimodality approach, as I said. We use surgery, radiation therapy, chemotherapy, hormone therapy, and targeted therapies. And now we also are looking at molecular profiling that is showing us the presence of some mutations. The prognosis and selection of therapy has always traditionally been influenced by the patient's menopausal status, whether they are premenopausal, postmenopausal, the stage of disease, the grade of the tumor, how aggressive it is, whether they're hormone receptor positive, HER2, if there's HER2 amplification, the different histological types that tell us how aggressive the cancer could be, and the patient's age, general health, are all considerations. So this is going back to 2005. This is from the early breast cancer trialist group. It was a landmark study that basically showed that there is definitely a risk reduction of relapse and mortality with polychemotherapy. So what on the left side you see the benefit of polychemotherapy on recurrence. On the right side it's mortality. And on the top two graphs, it's for patients who are less than 50, and the bottom two are for 50 to 69. And then you can see that both age groups do benefit from polychemotherapy, but the greatest reduction in recurrence and mortality is clearly those who are less than 50. So these are some examples of the many chemotherapies that we use to treat breast cancer. Adriamycin and Cytoxan and Taxotere and Taxol are mainstays in the adjuvant setting, in the initial setting when we're treating to cure. Carboplatin is now being more used for the more aggressive cancers, such as the triple-negative cancers. It's effective in BRCA-mutated cancers because it also causes DNA damage that needs to be fixed with homologous repair. And BRCA-mutated cancers already have a problem with homologous repair, so it's like a double hit to those cancers. And the other chemotherapies we often used in the metastatic setting, such as navalbine, Gemzar, ixabepilone, Abraxane, so a lot of those. So these are examples of the hormonal therapies for early stage and locally advanced breast cancer. We definitely have seen development of many different kinds of therapies over the past 15, 20 years. Things started off with tamoxifen many years ago, and now we definitely have a much larger armamentarium. So tamoxifen is a pill. It's a selective estrogen receptor modulator. It acts as an antagonist in the breast, but it's actually a partial agonist in the endometrium. That's why there is a slight risk of endometrial cancer in the younger patients, which is a concern. Then we have aromatase inhibitors, anastrozole, letrozole, exemestane. These are all aromatase inhibitors. They're pills. They block aromatase enzyme that will convert androgens to estrogens in the postmenopausal female who is not making estrogen from the ovaries at that point. So at that point, postmenopausally, most of the estrogen is converted from androgens produced in the adrenal glands. Fulvestrant or Faslodex is given IM, and it's a pure anti-estrogen. And Grosserolin and Leuprolide are given IM, and they are used for ovarian suppression, especially in the younger females. Yes. Intramuscular. You're welcome. Okay, so this is from the early breast cancer trialist group back from 2005. Again, a landmark study that people still quote and show. It is showing the benefit of tamoxifen as an adjuvant treatment. So most of the effect on recurrence comes in the first 5 years. On the left side, you'll see recurrence, and on the right side, the graph is showing mortality. So most of the effect on recurrence comes in the first 5 years, but the 15-year gain is 11.8% as compared to the control group. So women who are not treated with, or women who are treated with tamoxifen, if they're hormone receptor positive, there's a big gain in disease-free survival over time. And similarly on mortality. This is also a landmark trial, again, by the Early Breast Cancer Trialists Collaborative Group. This was published in The Lancet in 2014. It's showing tamoxifen followed by, so when you sequence the hormones, you give tamoxifen, and then when a woman finishes the course of tamoxifen, you can start an aromatase inhibitor in the adjuvant setting when you're treating to cure, that there is benefit. So when an AI is, aromatase inhibitor is sequenced with tamoxifen, there is a further 2% 10-year gain in recurrence. So that is a significant benefit. And then for mortality, there's a 1.5% 10-year gain on mortality, or 1.5% improvement over not sequencing with the aromatase inhibitors. Oh, did I just go backwards? All right, so this list is definitely growing. These are examples of targeted therapies in breast cancer. This is probably the longest list. So we have trastuzumab, also known as Herceptin. It's a humanized monoclonal antibody that binds selectively to the HER2 protein, as you all know, and it suppresses activity that would lead to cell proliferation. Pertuzumab is a similar agent, but it binds to the extracellular domain 2 of HER2, and it inhibits HER2 ligand-dependent HER2/HER3 dimerization, and therefore it inhibits the signaling cascade. Then there's adatrastuzumab emtansine. That is Herceptin that's bound to a chemotherapy, toxic chemotherapy, emtansine. So basically, they're using Herceptin to deliver the chemotherapy in a targeted way. Lapatinib, also known as Tykerb, is a tyrosine kinase inhibitor. Everolimus, also known as Afinitor, it's an mTOR inhibitor. So these are the PARP inhibitors, olaparib and talazoparib. And so olaparib was approved in January 2018. It's a PARP inhibitor. And so it's actually the first targeted therapy that was approved for germline BRCA mutated breast cancer. So the theory is that since BRCA mutated cells are incapable of homologous repair of double-stranded DNA breaks, additional PARP inhibitors, so additional, like the PARP pathway will help in the single-stranded DNA break. So cells that are BRCA mutated would rely on other pathways for repair of their DNA. And so if you are inhibiting both pathways, that will result in genomic instability and cell death. So that's a long way coming, you know, for a BRCA mutation. I think this is a long way coming. But talazoparib was actually just approved last week. We just had a journal club on it this morning. It's the second PARP inhibitor approved in breast cancer. Again, it's approved for germline BRCA mutations. And so very exciting. Okay, so what happened? Okay. So more targeted therapies, palbociclib, ribociclib, abemaciclib. These are all CDK4/6 inhibitors. So aberrations in the CDK-RB pathway are common in breast cancer. Consequently, when you inhibit this pathway, it's pretty attractive as far as a therapeutic strategy. So inactivation of CDK4/6 cyclin D1 complexes will control cell growth by inducing G1 arrest and preventing cells from cycling going into the S phase. So these are the 3 that are approved. So how do clinicians make well-informed decisions about which patient to treat with chemo and what to choose? So treating breast cancer in the genomics era. So we always will have to look at the basics, such as tumor size, molecular subtype, histology, pathological grade, nodal status, hormone receptor expression, patient's age, comorbidities, all these things. We're never going to get away from that. But now we're also using gene expression profiling of the primary tumor to predict response to particular agents. And we're also using gene expression profiling of the primary tumor to predict and treat only those patients who are most likely to recur and who will therefore benefit from the addition of chemotherapy. And that's a huge area that has made big strides actually just this year. And I'll talk more about that. So what are genomic tests? The difference between genomic and genetic testing. Genetic testing involves sequencing a person's DNA. But however, in the context of cancer medicine, genomic testing identifies the abnormalities that dictate how a patient's tumor behaves. So in the last decade, we have seen the emergence of genomic profiling assays of primary breast tumor that allow us to better look at the risk prognostication and predictive benefit of adjuvant chemotherapies. So all of that started with this Sorley study in PNAS in 2001. So this was the beginning of it all. And so gene expression patterns of 85 samples were analyzed by clustering using 476 intrinsic cDNA clones. And the tumor specimens were divided into 5 or 6 subtypes based on the different gene expressions. So the cluster dendrogram that you see on the right over there, they were able, based on the expression of genes, they were able to divide up all the cancer types as in putting them into luminal subtype A, B, C, normal breast-like, basal-like, and ERB2. And that's how they divided them up based on gene expression. So this would provide a means for identifying expression motifs that represent important clinical phenotypes. So we were able to see which particular groups have resistance to specific therapies, sensitivity, which are more tumor invasive, or which groups are have a bigger metastatic potential. So they wanted to know whether this molecular profiling was useful in determining breast cancer prognosis and treatment strategy. So once you develop something, then you need to validate it and see if there's any utility to it. So they did a survival analysis on a sub-cohort of patients with locally advanced breast cancer who were uniformly treated in a prospective study, and they were able to show different outcomes for the patients belonging to the various subgroups that were identified by the gene profiling. And they found that, as you can see on the graph here, that the luminal A subtype, which is represented by the top line, appeared to have the best prognosis, and the basal-like had the worst prognosis. So it basically validated that the gene profiling does identify different groups with different prognostic features. So this is from 2017. So they're basically saying that gene expression arrays can categorize breast cancer by molecular subtype and inform prognosis. So what the Sorley paper had described as luminal A, we now further know that the luminal A are the ones that do have the better prognosis. They are the ones who are hormone receptor positive, they have low Chi-scores, a low grade, they have a favorable prognosis. These are the ones that we could probably use standard just endocrine therapy, and they do not have high penetrance mutations, for example. It goes down a continuum and looks like what they were terming basal-like with the worst prognosis is actually triple negative cancers, which are very aggressive with a high Ki67, high grade, poor prognosis. you have to use chemotherapy, and likely they have high penetrance mutations such as P53 and likely BRCA mutations as well. So this is a summary of different molecular tests that we commonly use for breast cancer currently in clinical practice. ERPR, we look at a protein for expression. We look at HER2 protein for overexpression. We look at the tumor DNA for HER2 amplification. What we're doing a lot of now is we're looking at tumor DNA for gene panel testing. And so basically, even though a lot of, mutations that may be identified, there is no FDA-approved therapy targeting those, but we can use that to direct patients to appropriate clinical trials looking at different targeted agents. The two tests that I'm going to talk about today, which are actually very important, the Mamoprint and Oncotype DX, they look at tumor RNA, and they basically are tests that select patients for, they predict reoccurrence and select patients for chemotherapy. So just briefly, the more important of the two is the Oncotype DX, but I'll just briefly mention the Mamoprint because it was probably the first test that was approved to be used as a recurrence assay that's in practice. It is a tissue-based genomics test which uses microarray technology to analyze a patient's breast tumor biology to predict whether existing cancer has the ability to metastasize. They used a validated 70 gene profile as a predictor. And so basically they looked at tumor specimens from 78 untreated breast cancer patients whose outcomes they already knew, and they analyzed those. And the entire genome was interrogated to determine which genes were most predictive of recurrence. And just of note, the different genes that were chosen, they interrogate all 7 genomic pathways of the metastatic cascade. So the Mamoprint assay was validated in 2 separate studies. One study back in 2006 found that that assay was able to fairly accurately classify patients into high or low risk with a statistically significant difference in the probability of disease-free survival at 10 years. And then another study in published in 2010 confirmed that those patients who were at high risk, who were actually put into the high risk category, derived a 12% absolute benefit when chemotherapy was added to their regimen. And those patients who were categorized as low risk according to the Mamoprint recurrence assay, they actually did not have any statistically significant benefit from adding chemo. So that was one of the first recurrence assays. But very importantly, the Oncotype DX is a molecular assay that's currently in clinical practice. It's more important than, it tells us more than the Mamoprint. So it is a prognostic test in that it provides information about how likely or unlikely the breast cancer is to come back. And that is similar to what the other test does, but it's also a predictive test in that it predicts the likelihood of benefit from chemo. So that is the main thing. This is the feature that makes it different from the other recurrence assay that we just talked about. So how did they develop this test? This is definitely translational research at its best, because we have actually come to at this year's ASCO, we came to a conclusion with the results. So these are all ongoing things that have been going on in the laboratory for at least 20 years. So an RT-PCR method was designed to quantify gene expression and prognostication. It was initially validated for ER-positive, HER2-negative, node-negative invasive cancer. So it's been expanded to the node-positive as well, but that was the main cohort of patients that they were looking at for the Oncotype DX. So 250 candidate genes were selected from the published literature, genomic databases and experiments based on DNA microarrays. And then those with prognostic significance were identified using 3 independent clinical studies of breast cancer involving 447 patients to test the relationship between the expression of the 250 candidate genes and the recurrence of breast cancer. So 16 cancer-related genes were identified from those panel of genes that fell into 3 groups. There was a proliferation group, an ER-related group, and an invasion-related group. And then several just other random genes, and then they had some housekeeping genes. And then an algorithm based on the levels of expression of the genes was used to compute a recurrence score for each tumor sample being tested. So based on the expression of the different genes in each tumor, they came up with a recurrence score. So once they had developed those genes as a predictive model, those 16 genes, now again it had to be validated. So they used the B14 study to validate the Oncotype DX. So based on retrospective analysis, the assay and recurrence score were validated as quantifying the likelihood of distant recurrence in tamoxifen-treated patients with node-negative, ER-positive breast cancer. So you can see that based on the recurrence score, those people who had a high recurrence score, they had a high likelihood of disease coming back. And those who had a low recurrence score, they were put in the low risk group, they had a low distant recurrence rate. So this is basically, again, a validation study. So patients with tumors that have high recurrence scores have a large absolute benefit of chemotherapy. You can see the graph on the right side. These are the patients who had a high recurrence score, meaning they have disease that had a high likelihood of returning. And you can see that the graph on the right, the difference between the 2 groups. The green one shows the green line shows chemotherapy plus tamoxifen, and the yellow line is just tamoxifen alone. And the people who in that group who received chemotherapy had a longer time, had a better disease-free recurrence rate. And for those in the low risk score, there was not much difference between the 2 groups, whether or not you gave chemotherapy. But the confusion was in the people who were in the intermediate group on what to do, whether to give chemotherapy or not chemotherapy, and how to predict which ones would benefit from chemotherapy. So to answer that question, the TAILOR-X study was designed. This was a landmark study, a huge study, actually, that was just revealed. I've been presenting this study probably ever since I've been presenting this in this course, and the results finally came out at this year's ASCO, and it's definitely a landmark study. It's a landmark clinical trial. It supports the use of Oncotype DX breast recurrence score. It enrolled greater than 10,000 women aged 18 to 75 with hormone receptor positive, HER2 negative, node negative, early stage breast cancer in over 1,000 trial sites in 6 different countries. It was led by the ECOG Akron Cancer Research Group, and this is a CTEP-sponsored trial, actually, here at the NCI. So the goal, actually, what really everybody wanted to know was, can we spare the toxicity of chemotherapy in women who do not need it? So it was clear that women with a high score would benefit from chemotherapy, as I showed you in those graphs. And those with a low score would not. But the gray zone is definitely, in the mid-range where we don't know. So that was really the main primary study group for the TAILOR-X, is to find out whether, what about that mid-range group. The high numbers that were enrolled, there were 6,711 in that intermediate group. And the numbers were driven by having enough patients in that mid-range group who could answer this question. So the 9-year follow-up was just reported at this year's ASCO and published in the New England Journal. And there is this is huge. There's no statistically significant difference in invasive disease-free survival among patients with recurrent scores in the intermediate category of 11 to 25 who were assigned to endocrine therapy alone versus chemoendocrine therapy. So you can see that on the graph at the right. The graphs are just overlapping. The red one is the high-risk patients, and we know they're going to, despite getting chemotherapy, they will have events that occur. But the two top, the low risk and the intermediate risk, they're just right on top of each other. So for risk score 26 to 100, like I said, again, they were going to have events despite anything. But the one thing I have to say is that an exploratory analysis did say that chemotherapy will benefit patients who are 50 or younger who are in the intermediate group, and that subset is about 8% of patients. So physicians do have to, for the younger patients, I think physicians do have to step back and take a look at the different criteria and decide whether or not chemotherapy would be beneficial for that particular patient. So there was no statistically significant difference between treatment groups also in the probability of distant recurrence at 9 years follow-up. So this is definitely excellence and success in translational research in clinical oncology. I think this has been a long way coming. A lot of studies, a lot of validation studies, a lot of laboratory work that has gone into coming to fruition. So now, finally, adjuvant chemotherapy in early-stage breast cancer may now be guided with an unprecedented level of evidence and precision. The TAILOR-X 9-year follow-up analysis has shown that the 21-gene assay can identify 70% of women with no chemotherapy benefit, as well as identify those in whom chemo might be life-saving. So this is definitely very important work in clinical oncology. So what are the clinical implications of molecular diagnostics in breast cancer? So treatment, like I said, is becoming more personalized for all patients. So some things that we are doing, this next-gen sequencing, it's becoming increasingly used to identify potentially actionable mutations in tumor tissues. The Cancer Genome Atlas study published in Nature profiled 500 tumors and found that about 10% of all tumors had more than 6 mutations. Most tumors either had no mutations identified in the top 40 cancer-related genes or had just a few mutations. And specifically in breast cancer, there are not as many mutations in cancer-related genes. So a big part of research right now is profiling of metastatic tumors in our patients and looking for different mutations and trying to identify whether these mutations are passenger mutations or driver mutations. So what are the current guidelines for genetic testing? The biomarkers we always test for, ER, HER2, perhaps BRCA, but now that we are more interested in identifying BRCA mutations, especially in triple negative, it is recommended by national guidelines. Next-gen sequencing is actually not recommended as standard of care, but most academic institutions, they definitely do it. I mean, I work with the NCI referrals office to take a look at patient records and try to put them, place them with the correct clinical trials, especially for the women's malignancy branch. And most patients coming from academic centers, they have next-gen sequencing that's being done, and so we're able to see what clinical trials may be best suited for those patients. So a similar trial is being done here at the NCI in the DCTD. It's been ongoing since January 2014. The NCI MPACT trial. The purpose of the trial is to assess whether assigning treatment based on specific gene mutations can provide benefit to patients. And what they do is during the screening process, they actually look at samples of tumor from patients and they genetically sequence and they look for certain different gene mutations. And so if they find mutations of interest, then those patients are enrolled on the trial, and then they're randomly assigned to either to one of two arms of the study. One is a targeted arm, and the other is a non-targeted therapy. So what this trial will answer are these questions. Right now, what we don't know is whether using this approach is really effective at providing clinical benefit, and I would say it likely is. Most tumors have multiple mutations, and it is often not clear which one to target to achieve maximal benefit. But then that's why we're doing clinical trials with combination agents. So once a gene is mutated, it can lead to the activation of multiple pathways, resulting in disease progression and potentially requiring several interventions. So NCI's MPACT trial is designed to determine whether people with specific mutations will benefit from a specifically chosen targeted intervention, leading to better outcomes. So just briefly, I'm going to present a few slides showing breast cancer trials with our group. So just a little background, I'm sure all of you are aware of the PD-1, PD-L1 pathway and inhibitors, and just immunotherapy in general. The Nobel Prize in Medicine went to Dr. Ellison this year from MD Anderson, who has done pioneering work in this area, and here at the NCI we do a lot of trials with these agents as well. So the PD-1, PD-L1 pathway represents an adaptive immune resistance mechanism. PD-L1 is commonly expressed on tumor cells and binds to PD-1 receptors on activated T cells, which leads to the inhibition of activated T cells. So inhibition of this pathway using monoclonal antibody directed against either PD-1 or PD-L1 is definitely an attractive therapeutic strategy. So I've already talked about PARP inhibitors and what they do, but in general, tumors that harbor a defect in homologous repair are highly vulnerable to PARP because they now rely on other methods of DNA repair. And if you knock out the PARP, you are hopefully causing genomic instability and cell death. So what is the preclinical rationale for combining PARP inhibitors with PD-L1 or PD-1 inhibitors? So preclinical studies have shown that PARP inhibitors upregulated PD-L1 expression in breast cancer cell lines in animal models. We have seen that PARP inhibitors dampened anti-cancer immunity via upregulation of PD-L1, and subsequently blockade of PD-L1 resensitized PARP inhibitor-treated cancer cells to T-cell killing. And the combination of PARP inhibitors and anti-PD-L1 therapy increased the therapeutic efficacy also in vivo compared to either agent alone. So we have a trial in the women's malignancy branch looking at durvalumab, which is a PD-L1 plus olaparib for advanced or recurrent triple-negative breast cancer. So I'm not going to say too much about it, but so durvalumab, it's given intravenously once over a 28-day cycle, and the patients take olaparib twice a day, daily, and one cycle is considered 28 days. They get imaging every 2 cycles. We follow RECIST criteria. We're looking at response rate. If the patients progress 20%, we identify baseline lesions, which are called target lesions, and if the patients progress 20% from the baseline, we consider that progressive disease and the patient will come off study. If the patient continues to have stable disease, they continue on treatment. And if they have a 30% regression of target lesions, we consider that a partial response. So we have actually had some good responses. This this clinical trial is ongoing. But we have had some good responses. So check inhibitors. So check kinase 1 and 2 are cell cycle regulators. They are associated with cellular response to DNA damage and repair. So they halt the cell cycle basically to allow DNA to repair. So cells with defects in the DNA repair pathways will accumulate damaged DNA and then eventually die if CHEK1 and CHEK2 are inhibited. So we have a trial in the women's malignancy branch looking at CHEK inhibitors. Also, the breast cohort is now closed for that, but analysis still has to be done. But we've had also good responses in this trial. And we've had, it's a similar, I'm not going to get too much into that, so I'll just move on. And I think I'm running out of time, but we also are looking at, I'm going to skip this, but TDM1, it's a HER2-directed antibody drug conjugate. And I think I'll just move on. So I'll just mention ONC201. This is coming out of our lab. So ONC201 was originally identified as a small molecule that induces transcription of TNF-related apoptosis-inducing ligand, or TRAIL, and subsequently kills cancer cells by activating TRAIL death receptors. However, in the lab, we examined ONC201 toxicity on multiple human breast and endometrial cancer cell lines, and it showed attenuation of cell viability. But unexpectedly, the mechanism was not what we had thought it was. It does not work through TRAIL. Well, we don't really know exactly what the mechanism is, but we know it's not TRAIL and it's not caspases. Time-lapse live cell imaging showed that ONC201 actually induces cell membrane ballooning, and it causes rupture, and that's distinct from the morphology of cells that are actually undergoing apoptosis. And so the further laboratory studies showed that it actually induces phosphorylation of AMP-dependent kinase and ATP loss. Cytotoxicity and ATP depletion were enhanced without glucose, and that would suggest that ONC201 targets mitochondrial respiration. So other laboratory studies show that ONC201 decreased mitochondrial DNA, and RNA-seq showed that it suppressed expression of multiple mitochondrial DNA-encoded genes involved in oxidative phosphorylation and other functions. So this is a transmission electron microscopy from our lab that's showing ONC201 induced structural damage in breast cancer cell line T47D. The cells, the time is increasing as you go down, and the right panel is showing a higher image. And you can see that there's a mixed phenotype of damage. There's matrix lysis, crystallysis, and fragmentation rather than uniform mitochondrial swelling. So we know that ONC201 inhibited mitochondrial oxygen consumption, but it does not inhibit glycolysis. ONC201 induced toxicity and ATP depletion were enhanced in non-glucose medium and reversed when glucose is resupplied. So these data suggest that ONC201 kills cancer cells by disrupting mitochondrial function. The data further suggests that cancer cells that are dependent on glycolysis will be resistant to ONC201. But the question always arises, so why is this not toxic to normal cells? And we don't exactly know the answer. It's possible that normal cells may switch to glycolysis in a situation such as this when it's exposed to ONC201. But further research needs to be done to further elucidate the mechanism. We have translational research. We do have a clinical trial, a phase 2 trial for metastatic breast and endometrial cancer. And it's currently open to accrual, and so remains to be determined how it's doing in the laboratory, in the clinic. Sorry. Am I out of time? All right. So things that we'd like to do in the future. So we will continue to use our rapidly increasing knowledge in the fields of cancer genomics and cell biology to identify actionable mutations. That's the big thing. Establishing biomarkers, that's huge. Biomarkers that indicate response and treatment, if a patient is going to respond to that particular treatment. And we'd like to use that knowledge to more effectively treat our patients. Identifying those who are more likely to recur, sparing the toxicity of chemo for those women at low risk. And I'd have to say a lot of these things on the list we're already well on our way to accomplishing. So we will continue to use and improve this knowledge to tailor breast cancer therapy to the individual patient. Gene expression analysis has led to the identification of 5 subtypes of breast cancer that have distinct biological features, clinical outcomes, and response to chemotherapy. So this knowledge can be exploited in the continued development of treatment strategies based on specific characteristics of each tumor. Furthermore, a patient's response to chemo is influenced not only by the genetic characteristics of their tumor, but also by inherited variations in genes that affect the body's ability to absorb, metabolize, interact with, and eliminate the drugs. Our growing knowledge should enable prediction of tumor responses to individual chemotherapy drugs or classes of drugs, as well as the likelihood of severe adverse events from that. And a lot of that, again, we have been able to do. And finally, we will use our increasing knowledge of the immune system to enhance the body's ability to recognize and destroy cancer cells. Breast cancer is one of the major cancer types for which new immune-based cancer treatments are currently in development. Cancer vaccines, checkpoint inhibitors, I've already talked about them. We're doing a lot of that in the women's malignancy branch. So we look forward to using advanced technologies, including genomics, to improve our ability to detect breast cancer at its earliest stages. And very importantly, we will strive to understand, address, and eliminate factors that contribute to the higher mortality experienced by African American females, and compared with females of other racial and ethnic groups. And that's it.
So our next speaker is Neil Caporaso. He was an undergrad and got a master's degree at Rutgers. He got his MD at the University of Medicine and Dentistry of New Jersey. He did a residency in internal medicine, and then he became an oncology fellow at NCI. He served as a research fellow, a biotechnology fellow, and then he became chief of the pharmacogenetics section in the Division of Cancer Epidemiology and Genetics. And he's going to talk to us about epidemiology. Neil.
Thank you. First of all, I know you all sat through the last talk and we're a few minutes over, but if anyone wants to take a quick break, like 1 minute, I'm just going to blather for 60 seconds, so feel free. One thing I'll tell you is that I have a substantial number of slides. I'm not going to go through every single one of them, but I want to give you an overview of the principles, some of the basic features of epidemiology. Give you some examples, point out some controversies. I think that if you want to look up a specific risk factor for a specific cancer, you can get that from the handout or you can look it up. But I want to give you kind of a broad map of the area, kind of get some idea. So that was about 60 seconds, right? I'll mention that I'm going to use lung cancer and obesity as examples. So while we're talking about diverse principles and types of bias, I'm going to try and draw in examples from those two areas. I've been studying obesity the last few years, and I found it so fascinating that I'm taking the exam to become board certified in obesity medicine. So it's kind of a slightly new career direction. So what is epidemiology? Is the study of the manifestations of disease in populations, not in cells, not clinically, but how it manifests in populations. And it's a changing landscape. Without the science of epidemiology, without solid science, we're left to advertisers and market forces to determine what we think is good and bad. And so here you can see some advertisements which show the good doctor. Whoops. I'm trying to make the laser work. Maybe I'll just gesture. Showing some positive advertising for cigarettes. While there's generally a public perception that cigarettes are bad, there's not necessarily the same perception about food types, but there's accumulating data that sugar may in fact be as dangerous in some ways as tobacco, and so I'll touch on some of that data. So epidemiology is concerned with human populations, and it's an observational science which you contrast with an experimental science. So that's a fundamental difference. The investigator doesn't always get to pick who is exposed or unexposed. I'm in a division of cancer epidemiology and genetics in the Occupation and Environmental Epidemiology branch, and we pretty much exclusively do epidemiology studies. And as you know, NCI is part of NIH, and DCEG is part of NCI, and this is our branch. So our division has been responsible for a lot of changes in clinical practice, regulatory changes, preventive interventions, and I won't go through them. But the goal is to identify the environmental and genetic causes of cancer. So we don't do treatment. We basically investigate causes of cancer. And there are collaborations around the world. We have studies in China, studies in Iran, pretty much everywhere in the world. So if you go to our website, you can find lots of interesting information and cancer risk assessment tools, and this is kind of there for your reference. So just another word about observational versus experimental. We can't ethically do experiments on people. We'd love to do randomized clinical trials, but you can't randomize people to smoking tobacco or to getting fat. So we have to start with populations, and that imposes certain difficulties. The key difficulty is that you have to deal with confounding variables. And there's a hierarchy of studies, and this is something you'll hear a lot about. Like, you'll always hear, well, they should do a randomized clinical trial to test this and not rely on just observational studies. And that's true. We should do randomized clinical trials. The problem is the costs. So anecdotes cost nothing, and that's typically where study ideas come from, or small selected unrepresentative samples. And again, the cost of those kinds of studies is pretty cheap. But then if you do a large study, a cross-sectional study or a prevalent study, it costs more. And if you organize people into case and control series, that costs more. And then the most expensive kind of observational study is a cohort study, because it takes so long and requires such large numbers. And it typically costs in the millions of dollars. And then if you actually do a randomized clinical trial, it's super expensive. So there are reasons for doing each one of these studies, but a key reason is the cost. In fact, I'll give you a few examples of lung cancer studies, but we did a large lung cancer case control study in the 90s where we had 2,000 lung cancer cases newly diagnosed and 2,000 controls. And the initial cost of that study was $12 million. So even though we're in this type of study and not a cohort study, it's still very, very expensive. And you might say, wow, if you're spending that much money, why didn't you do a prospective cohort study where you start from a large population and follow them over time? And two of the big disadvantages of cohort studies are that it takes decades often for people to develop the disease of interest. And also, since you're studying a large population and you have a wide variety of endpoints, you can't focus your questionnaire narrowly enough to get in-depth information. So we wanted to get very in-depth information about lung cancer. So to do that, you really required the case control study. And we also wanted tissue. Very hard to do in a cohort study. In a case control study where people are diagnosed in a hospital, you can often work it so that you can get into the operating room and actually get tissue. So I'll touch on that again. So again, the goals of epidemiology: identify the causes of cancer, identify risks and risk groups, improve public health, identifying syndromes, trends, epidemics, understand mechanism, and ultimately prevent cancer. Epidemiologists will always emphasize prevention. Why is this? Because prevention saves many, many more lives than treatment. This is pretty much, a standard statement, and that's because prevention is effective, cheaper. You're dealing with public health. You eliminate disease at the source. There are some downsides, though, to prevention. One is that it takes a lot of time to demonstrate its effectiveness. It's not as dramatic as treatment. There's no one coming to thank you for preventing disease. And you can't go to Congress and say, well, you can say we prevented disease, but you don't have grateful patients saying, oh, the new treatment was so wonderful. You don't get Nobel Prizes for prevention. Dahl and Pito, who identified tobacco as a risk factor for lung cancer in the 1950s with a classic case control study, really were never recognized with the Nobel Prize, although you can argue they saved hundreds of millions of lives. Epidemiologists worry about bias, and bias is defined as systematic deviation from truth, and there are lots of kinds of epidemiologic bias, but one paradigmatic kind of bias is participation rates, and that is when you define an epidemiologic study, some people get into the study and some people don't. And that's termed selection bias because the people you may be accruing may not be representative of the population at large. And so that can introduce problems and make your study not generalizable. So an example of this is that when we did our big case control study, the one that was going to cost $12 million, our site visitors said, well, what percentage of the eligible controls are you getting in this study? And so we did a phone survey, and it looked like only 30% of people would participate that were eligible. Now, you can understand this. If you're at home and you get a phone call and say, hey, we've randomly selected you to participate in a study, and the questionnaire is going to take an hour, and we're going to get 70 cc's of blood from you and ask you a lot of sensitive questions. What's the likelihood you would say yes? The likelihood is that no one would say yes. So we had to do things to up the participation rate. So this study was being done in the region around Milan, Italy. So we got an invitation letter from their family doctor. We followed up with phone calls. We said we'd study them in the hospital. We put advertisements around increasing the knowledge about the study. We gave them a cash award, and that increased the participation rate, estimated to 49%. Still not good enough. The site visitors said, we won't fund the study. So then we did two interventions that were decisive. One, there was a gas shortage at the time in Milan. We gave them a gas coupon, which was like a big deal. And we got new interviewers. These interviewers, we had male interviewers for the women and female interviewers for the men, and they were very charming. And they that helped. We had TV ads. We really worked hard to get the participation rate up. So, okay. Epidemiologists are frantically worried about controls. And you'll always hear we want population controls. But what you don't hear about, the gold standard method to identify population controls is random digit dialing. You call people up. Well, today that just doesn't work. Okay, you can call people up and they think it's a robocall or it's political, and so it's very hard to get population controls that are representative. And so this is an issue. So if you read the methods of an epidemiologic study and they say population controls, you better ask about the response rate, because most cohorts, most large population cohorts have a response rate under 5%. So that's an issue, and it's a problem. If you call your epidemiologist as a consultant, they're going to ask you about your design, where your controls came from. Did you get covariates so you can adjust for confounding? In other words, are your case and control populations comparable for age, gender, ethnicity, smoking? What was your original hypothesis? Many times people get a ton of data and they torture the data for associations and then maybe publish something that wasn't the initial goal of the study, and that's always a problematic issue. A common question that epidemiologists get is, I know, I have a grandmother, she smoked, she didn't exercise, she ignored her seatbelt, she drank shots on her 90th birthday, but she outlived all her doctors. And that's the issue, that epidemiologic studies deal with probabilistic data, and there can always be an outlier. That's just the nature of the beast. So I'm going to just mention a few common tools. Cancer mortality maps have been a tool to use in epidemiologic analysis. And this shows the distribution of melanoma, which is more common in the southern part of the state because sun exposure is a risk factor for melanoma. And geographic information systems are expanding the scope of these kinds of studies, and could give a whole hour talk on GIS. SEER is a wonderful tool to look at the United States population, and it covers 11 states and a few urban areas, 26% of the US population. We've done some really nice studies looking at SEER data. We have a study looking at the influence of circadian disruption using SEER, and we're getting ready to expand the study to all 50 states. And there's another group that uses the registries for all 50 states, so you can expand the study beyond SEER. So I won't go into this too much, but I'll just mention that cancer incidence rates often require some interpretation. So here's 1975 to 2000, and in men, there was a big increase in cancer rates. And what was the cause of that increase? And so when you break it down by gender, you can see it's in men and not in women. And when you break it down by malignancy, you can see it's in prostate. And it turns out the reason for this is that PSA screening was introduced, and that increased the number of cancer cases that were discovered. Another interesting thing you can get from cancer rates is differences between incidence and mortality, and that often means that we have an effective treatment. So here's childhood cancers, and it's an example where for many childhood cancers, treatment is effective. Unfortunately, we don't know that much about the etiology of many childhood cancers. So epidemiologists are very concerned with cause. And what's the cause of a particular cancer? And one reason for this is that we use statistics to tease out associations. And if there's one thing you remember from your early training in epidemiology, is that correlation doesn't prove causation. And this is true. And so epidemiologists have a number of criteria that they use to try to infer cause. These are called the Bradford-Hill criteria. And there's more modern and emerging methods to investigate causality: mediation analysis, Mendelian randomization using genetics, and molecular epidemiology using biomarkers. And if anyone wants to read about these methods in depth, there's a cool new bestseller called The Book of Why. and I recommend this book. It has some great chapters on each of these approaches. So the Bradford Hill criteria, the most epidemiologic approach, these still work pretty well. If you want to prove a cause, factors that support causality are that it confers high risk rather than low risk. It's consistent in different settings. There's a dose response. You want to have the correct temporal relationship. The cause should occur before the disease, and the biology should make sense. In other words, you should have a plausible mechanism. One issue with mechanism is that there's so much scientific work today in the literature that almost anything that you find, you can do a search and you're going to find something that you can backfill into your study. So you can't cheat with this. You really need to do it correctly. So lung cancer is associated with cigarette smoking. The odds ratio is 20. That's a substantial odds ratio. Colon cancer is associated with red meat. The odds ratio is 1.2, which means a 20% increased risk. So which is more plausible? I'm going to go with the cigarette smoking. Low risks tend to have problems. First, the risk may be significant on a population level. Yes? Yeah, 20-fold. 20-fold. So a active current smoker has a 20-fold greater risk, 20 times than a non-smoker. So low risks, first of all, there's a difference between a statistically significant risk, a risk that's important on a population level, and a risk that's important clinically. Okay, if someone has a 1.2 increased odds ratio, is that clinically important? If you go to see your doctor? Not really. When you have low risks, you can have residual confounding, for example, from smoking. Meat eaters, and I'll touch on this a little more later, have a lot of confounding by other risk factors. They drink more alcohol, they exercise less, they have lower physical activity in general, or more sedentary, poor socioeconomic status, etc. And there are lots of dietary associations with meat, including sugar, processed fats, French fries, etc. So coming back to cigarette smoking, this is just a few slides to show you that we meet all those criteria. The risks are consistent. Whoops. In 3 cohort studies, there were 19 case control studies in the 50s that all showed smoking was a risk factor. And the most famous physician of the day, R.A. Fisher, said, well, you know, if there's bias, the bias is there 19 times, so I'm not convinced. And the tobacco companies weren't convinced. So they finally broke the bank and did a cohort study. In fact, they did 3 cohort studies to track. In other words, they started with a group of unaffected subjects and followed them over time. And when they did follow them over time, they found a consistent dose response with increased smoking and cigarette smoke per day. And they also found the temporal relationship that you'd expect. People started smoking, rates of smoking increased in the population, and that was followed by the rise in male lung cancer. And then they saw a similar relationship in women. And they did mechanistic studies, the famous smoking beagles done by Oscar Auerbach in New Orleans, where they showed the histologic changes in the beagles matched those that you saw in lung cancer. So, you know, you met all the criteria. And they also showed that when people quit smoking, their rates took roughly 2 decades to return to baseline. They never quite returned totally to baseline. But again, the results were highly consistent. And so even though you didn't have a randomized clinical trial, the evidence was overwhelming and decisive. Okay, so what other kinds of things has epidemiology accomplished? And quickly, besides tobacco, I think it's important to note that identifying tobacco as a risk factor enabled studies of secondary tobacco smoke, and this gave us clean air laws. That was a benefit that all of us enjoy. So DCEGR division has done work in crisis communications, and these have been studies in silicone breast implants, Chernobyl, oral cancer and alcohol, not a risk factor, abortion and breast cancer, not a risk factor, cell phones and brain tumors, no evidence. We sent a team to the Fukushima disaster, and of course there are very active studies in HPV and cancer. General risk factors for cancer, we only have another 20, 25 minutes, so I'm going to skip over this. And I think this is something that you can look at. But I will say that population data basically implicates the environment in most common cancers, and that the effects, the rates by geography and over time are only compatible with extrinsic environmental causes. And one slide that encompasses a lot of data shows the rates where a particular cancer is highest and lowest. So here's melanoma, and you have the highest rates in Australia, a combination of sun exposure and the ethnicity of the population that tends to be of Northern European extraction, red hair, highly vulnerable to sun damage, and lower populations where the rates are lower. So genetics definitely makes some contribution, but most of these differences, when you analyze them, are due to the environment. And also an area that I can't go into because I don't have time is that migration studies tend to show that when populations migrate from low incidence areas to high incidence areas over the course of a generation, they acquire the rates of the new population. Cancer maps also implicate exposures. This was a smelter that was spewing copper and other pollutants into an area in Montana, and when the smelter was closed down, a little lung cancer hotspot disappeared. In China, there's an area in Zhenwei that has the highest lung cancer rates in China, and it's a combination of indoor ovens. People vent the smoke or used to vent the smoke into the home, and outdoor pollution is what resulted in these extraordinarily high cancer rates. And those rates actually were reduced when they actually vented the fans and eliminated some of the practices like having these ovens called kangs, which were actually charcoal briquettes that were kept under the bed to heat the beds. And it's estimated that a substantial amount of reduction in cancer rates is possible by eliminating many known risk factors. Okay, tobacco's a risk, and I'm going to have to skip over this section of slides, but I think it's worth noting that the rates of smoking increased and peaked mid-century, and since then the rates of smoking have gone down. And with it, the National Cancer Institute has had a terrific benefit because there are 7 major cancers related to smoking, and those are all going down, and that reduction in rates translates to a reduction in cancer mortality. And it's one that we can claim credit for, but we're really going to also have to make progress against the other cancer risk factors to continue that improvement. Okay, so I won't go into environmental tobacco smoke, but I guess I will quickly mention that the studies of non-smoking spouses demonstrated that environmental tobacco smoke and meta-analyses was a risk factor, and this led to all of the clean air legislation that we enjoy, so that there's not smoking in planes, on movies, in hospitals, in the workplace. Tremendous benefit. I did some studies of light and intermittent smoking, which is the fastest growing type of smoking in the United States today, where people smoke intermittently. And it's common in many ethnic groups, younger smokers, less dependent smokers. And we showed in a paper in JAMA Internal Medicine that even if you smoke very small amounts intermittently, your risk of dying goes up substantially. Okay, so there's alcohol is the number 2 carcinogen associated with a number of cancers, and I'm gonna skip over ionizing radiation and non-ionizing radiation and infections and HPV and occupational carcinogens, diesel exhaust, and talk about what can go wrong. One thing is that for a variety of cancers, we don't understand the environmental risk. So while I've shown you some evidence, some lines of evidence that implicate the environment, we really don't understand so much about prostate, leukemia, brain, sarcomas, pediatric tumors. Lung cancer in non-smokers is the 7th leading cause of death from cancer. And I did a paper on this almost 15 years ago. We still don't understand much more about the risk factors. Many exposures thought to be important are difficult or impossible to access. And I'll show you an approach to some of these in some of the concluding slides, but basically areas that are not studied or poorly studied are sleep, chronotype, activity and inactivity. There are controversies in diet. Circadian disruption is poorly studied. Diverse pollutants in the environment are only studied in a very kind of small basis. So chronic lymphocytic leukemia is a cancer I've studied for many years. It's the most common adult leukemia, and no extrinsic environmental factors are known. Family history is the most important risk factor. There are also gaps on the genetic side, and again, I'm going to skip over most of the genetic portion, but genes do contribute to most, virtually all cancers. However, the genes associated with common cancers confer minimal risk. They tend to account for only a small portion of the risk. And to date, it's maybe slowly changing. They don't help so much with risk models. So I'll take 60 seconds and tell you about risk models. In lung cancer, you're probably aware that the National Lung Cancer Screening Trial showed a 20% reduction in mortality when people underwent screening helical CAT scans. And work from our group has shown that to make this most efficient, you want to identify a high-risk group. Well, how do you do that? Well, the best way to identify high risk is find the heaviest smokers. But if we had a biomarker of high risk, or if we had a number of genes that reliably predicted risk and could add them to the risk model, we could really focus on a small group at very high risk, and screening would be most efficient in that group. Same thing goes for every other malignancy. But we're not quite there yet. To date, we're working on it. Also, gene and environment clearly act together. And this could be a whole lecture. There's been, I often say, the ratio of gene-environment interaction discussion to benefit is probably the highest in any area of cancer research, because we haven't gotten a lot out of gene environment. But one day, I think, we'll understand that a little bit better. Cancer families exist, and risk is clearly concentrated in those families, and it's on a genetic and not an environmental basis. But for most of them, the genes remain obscure, although there are many examples of genes that we have identified. So I think this is probably an area that you're familiar with, that cancers somatically exhibit gene mutations. So there's germline or somatic mutations. And I'm not going to go into the basics of genetics, although we do use families, and we have tried to map genes in those families, and with some success. And population-based GWAS studies are available for every malignancy. So we did a study called EAGLE, Environments and Genetics in Lung Cancer Etiology, that I mentioned to you before, where we did 2,000 cases and 2,000 controls. And we have almost, over 100 studies published from that. And we did try to look at genetic factors. The first thing we did was look at family history, and we're able to confirm that if you have a first-degree relative with lung cancer and you adjust for every other risk factor, you end up with about a 60% increased risk, taking into account smoking and age and all the other standard lung cancer risk factors. This study was not traditional epidemiology, in the sense that traditional epidemiology takes exposure and disease and does statistics and tries to identify associations. What we added was biomarkers. So these initials just stand for biomarkers that are further along in the progression to disease. So if you just measure a biomarker in blood, like, say, cotinine, measuring nicotine, that's an internal dose. But if you look at tissue and you identify somatic mutations circulating in the blood, that could be an early marker of disease. So those are the kinds of things we do in molecular epidemiology studies. And then integrative epidemiology incorporates behaviors and outcomes. So it says, well, we discovered a marker associated with disease. If you have that marker, does it affect your outcome? Do you survive differently? Or does that marker indicate what treatment might be most optimum for you? To do this study, we actually went into the operating room with liquid nitrogen, and for the 700 or so of the 2,000 patients that were surgical candidates for lung cancer, most lung cancer patients are identified at advanced stage where they have metastasis, surgical therapy is not available to them. We've published a variety of studies looking at different mutations in these lung cancer patients. We also included food modules. So at the time we did the study, doneness was thought to be a risk factor, a dietary risk factor. The idea was that in meat, you have heterocyclic amines, which are produced as a function of the time and the temperature at which you cook the meat. So we rated doneness, and we thought, wow, we can estimate these heterocyclic amines and look at heterocyclic amines as a risk factor. And it turns out that it's not. And we included all sorts of instruments to look at behavioral factors, everything from depression, anxiety, addiction, the Fagerstrom nicotine dependency analysis. And we did lots of cool studies looking at the degree to which smokers were addicted. Turns out the degree of addiction is an important risk factor that adds onto other smoking metrics. And molecular epidemiology has made a lot of other contributions that I won't go into. And lots of times we use consortia to conduct these studies. So I'm part of 4 or 5 lung cancer consortia and we meet a few times a year and try to address questions for which the statistical power of any given study is inadequate. An example is studying non-smokers. So typically a few percent of your lung cancer cases are non-smokers, and we'd really like to apply molecular methods to see what's going on in those non-smokers. So we're basically going to the consortia, to every study, and saying, can you give us tissue blocks or available tissue or available blood? And we're going to do studies to try and find biochemical or molecular indicators of some exposure that may be triggering lung cancer in non-smokers. So that's also a fascinating area that we could go into. Phenex is an online resource that if you are going to do a study of, say, breast cancer, and you want to know what's the state-of-the-art questionnaire, you can go to this online resource and pull down the best questions. Or if you want to explore an area that hasn't been previously studied and you have no idea how to craft a questionnaire, you can go there and get one. For example, sleep is an emerging area that you could get from this resource. Okay, so those are standard challenges in epidemiology, but has epidemiology ever gone off the deep end and made some errors? And I'm going to say, yes, it has, although it wasn't because of errors in epidemiology. It's because the epidemiology was ignored in conducting the study. And one thing we should expect in the history of science, and this is Thomas Kuhn, is that models of what causes disease tend not to change gradually. Basically, there are adherents to these models, and we have to wait till they die. Or there's overwhelming evidence that changes the paradigm. And so I'll give you what may be one example of this. So here are obesity rates in the United States, and I find this to be staggering. And if you look at photos of people in the 60s and compare to photos of the general population today, you can see that the obesity rate as recently as 1990 was under 20% in every state, and now it's over 20% in every state. So here's just another map of the same thing. And here shows the progression change. It's shocking. And with that, diabetes prevalence has followed, and the diabetes belt matches the obesity belt. And this area generally is close to 20%. 20% of the population is diabetic. And I'm analyzing data from NHANES, population-based probability sample of the United States. And I'm shocked. More than half the adult population, this is 18 to 70 in the United States, is pre-diabetic or diabetic. It's absolutely amazing. This shows the trend. It's not just, we lead the world, the United States leads the world, but the same trend is present worldwide. And here is the United States leading the world. And we're worried about this at the Cancer Institute because being overweight, just like smoking is related to 7 or 8, 9 tumors, being overweight is related to 13 kinds of cancer. Why is this? Changes in diet, obesogens in the environment, changes in activity level. Some have hypothesized changes in the soil, the environment. Some have hypothesized that it's circadian disruption. And the cause of the obesity epidemic was addressed years ago, and it's a fascinating story of how the diet cholesterol heart hypothesis emerged, and dietary changes were recommended. If you go to the NIH cafeteria and you look for healthy products, what you'll see are products advertising less fat. More sugar and carbs results when you take fat out of food, and generally the fat that remains is processed vegetable oils. Because of those dietary recommendations made a number of decades ago, there have been macronutrient shifts in the United States diet. Carbohydrates have gone up, fat has gone down, saturated fat has gone down. And the food pyramid that has been recommended by the USDA basically has at its base carbohydrates. And all of the professional groups, the American Heart Association, Diabetes Association, have bought into these recommendations. And so the standard American diet, it's kind of a slide that shows that obesogenic rat chow, rodent chow, what you feed to mice when you want to have them gain weight, is similar to the macronutrient percentages in the American daily diet. So we have a mixture of refined carbohydrates and vegetable oil. What's in a donut? And so this may be something that's contributing to the obesity epidemic. So there is a raging debate now in nutritional epidemiology. And so I recommend anyone who wants to read about this, Johnny Ioannidis is a frequent critic of epidemiologic studies, and he's written a series of papers critiquing nutritional epidemiology. And Edward Giovannucci from Harvard has countered with other studies with, saying, no, actually nutritional epidemiology has done a very good job. And so I think this is fascinating articles to take a look at. And there's great points on both sides. But one point I think should be made is that I personally question the association of meat with cancer, because meat in questionnaires, you think you're referring to something like this, but in fact, meat consumption is associated with soft drinks and French fries and the bread and many other dietary and non-dietary exposures. So I think that residual confounding probably accounts for the meat association. So you can look at these slides if you want a little more detail on that. Okay, so here's some epidemiologic issues with prevention, and I don't have time to go into that in the last 2 or 3 minutes. Oh, and here's a slide. I mentioned that the low-fat recommendations that were promulgated in the 70s and 80s, they eventually did large clinical trials to try and show the effect of low-fat interventions. And unfortunately, a low-fat diet, basically the studies were null. I specifically remember when the branch chief of the nutritional epidemiology branch published the results of the polyp prevention trial in New England Journal of Medicine. And the result of an intense dietary intervention where they got people down to less than 20% fat, which is really hard to do. They would have a nutritionist, dietitian meet with them every week and counsel them on diet. And the results of the polyp prevention trial showed that the cases and controls were similar. The intervention group and the controls. So pretty much all these studies didn't show any results, any positive results. So to summarize, we need to look at diet. We need to look at other factors like light at night, and we need to look at the other factors that I mentioned to understand this a little bit better. I'll mention the light at night hypothesis. The idea is simply that during the day, we're in environments like this where we don't get any sun. At night, we are in illuminated environments where we're reading our cell phones, so we're getting light. Light at 760 nanometers triggers a pathway that goes to your pineal gland and suppresses melatonin. So without adjusting your circadian rhythm on a daily basis from getting bright sunlight, you don't reset your clock during the day, and you suppress melatonin at night, which is supposed to be high, the result of circadian disruption, many studies show that it alters metabolism in a way that favors fat storage. So this is a hypothesis that needs more work, and we're going to work on it. I don't have time to go into the insulin hypothesis, but I left a few studies here for anyone who's interested. Okay, so I'm going to conclude with a brief look at the future in the last 2 minutes. We're using technology to assess risk factors that we couldn't get at any other way. Capturing inaccessible exposures, get much more extensive data than typical questionnaire instruments, reduce misclassification. These kinds of approaches need data validation. And what am I talking about? I'm talking about sleep, physical activity, vital signs, circadian variation, social factors, location, and pulse oximetry. So quickly, sleep. Your watch, your Fitbit monitors your sleep. And so instead of asking people, when did you go to bed? When did you get up? How long did you turn in bed? What stage sleep? How long did you dream? Impossible to do this with a questionnaire, but these sleep kinds of monitors are increasingly sophisticated and able to track this data. So we're going to be able to look at sleep for the first time. I've published data from Haynes showing that when you get less than 6 hours sleep, you fall off a sleep cliff. And it increases your addiction propensity and increases your obesity, alcohol use, et cetera. Lots of bad effects. Make sure you get 6 hours sleep or more. Physical activity and inactivity, again, tracked through actigraphy. Vital signs, really useful thing to monitor. You can also monitor autonomic nervous system activity, your vagus, fascinating area. I mentioned circadian variation. Social data, really important. People tend to be in social networks that match their BMI and other behaviors like alcohol and smoking. Oxygen saturation is something that has not been studied, except very fragmented way. And you probably know that you can just get your cell phone out and touch the monitor and get your pulse ox from that. And so there's indications that pulse ox is related to mortality, low pulse ox. So it's something that can be studied. So I believe that all of these approaches, combining the best epidemiologic approach, genetics, biomarkers, and technology, is the way to get a risk model that will actually impact disease. So I think this is a great place to stop. And in the last 2 minutes, I'd love to answer questions. And I left my email there. Please don't hesitate to email if you disagree with anything or, yes. Thank you.
With all these cell phone data, gathering data and everything
Yeah.
like that, how do you first of all have people make species, like companies taking the data, making species claims up, but, or how do you protect patient privacy? What are the controls in place for that kind of thing? And how do you not get people excluded from certain things because like workplaces are now saying that you have to work a certain number of steps a day and all this based off data or
I don't have simple answers to those questions. Companies, I have companies are using the data and and selling the data 23andMe is using the genetic data. It's being used for good and bad things. I think abuses will emerge. You know, there's recently a paper published on genetics showing how they were able to track a killer based on data from 23andMe and identifying, oh, these 4 people are related, and so they were able to triangulate and find this person. There's going to be abuses, and there's going to be, you know, great uses, and it's very complicated and difficult. And I frankly don't think we're going to be able to keep people from being identified as this data emerges and is connected. So, you know, we're going to need new legislation and, you know, kind of proactive groups to look at this and make recommendations and, you know, to get the benefits of this without the abuses. So, yeah.
A follow-up question is there selection bias?
Yeah, there is selection bias, but it's getting less and less. Cell phones are, you know, they worry that the elderly and the poor, well, frankly, everyone has cell phones. And you can show in Africa people that, you know, literally they have nothing. They have cell phones. And that, you know, they're penetrating into society at a rate that's much faster than other technologies. So you could show how radio took 2 decades, you know, and TV took, cell phones are going faster than that. So they will reach an asymptotic point where essentially you're getting a pretty representative group.
How big of a difference do you think it is in data collection for apps and stuff compared to a more controlled, like, system environment? And, like, obviously there will be that variance, but like in your experience, do you think?
So the apps for foods are in their infancy, and they're data intensive. So, you know, there's an app called Chronotype, a chronometer, and you can go there, and there's another one, I forget what it's called, but it's very common. And, you know, you can, they basically have every food you can imagine, and you can estimate it, you know, a teaspoon, a tablespoon, you know, an ounce, a pound. You can put in an amount, and they have brand names, or they have it from basics, and you get the entire nutritional breakdown, you know, it's how much vitamin D3, how much of everything. And you have other apps so you can take a picture, and people are trying to integrate them into, but they're somewhat labor intensive. So, you know, if you go to, you know, go to a restaurant, and it's still difficult, how much ketchup did you put on? You know, and how much, all these condiments and things that add the bad stuff. So the progress is being made, but it's by no means a slam dunk. But food is harder than sleep, you know, or physical activity and your Fitbit. Yeah, yeah. Good luck capturing that. So sorry, I know there's a lot. Email me. Thanks.